Today we will see this case in which a hypermature cataract was managed by using phacoemulsification. Now these cataracts are unique in their own sense. These are very late presentation of cataracts and the cortex is already liquefied. The issue is also with the capsule, which is papery thin and fragile. There may be zonular weakness, and more so the liquefied cortex doesn't provide any cushion to the nucleus, which is free floating once the capsular excess has been done. So it is an empty bag with a free floating nucleus which is not at all stable during phacoemulsification process. So here you will see that once the capsule has been stained with trypine blue dye, we do go ahead and do a capsular excess, and as soon as the nick is made, we can see there is extrusion of this milky white fluid, which is liquefied cortex, which has degenerated over a period of time after the cataract has matured. And capsular excess is usually not an issue here unless and until the capsule is very turgid and there is raised intralenticular pressure, which causes bursting of the capsule once the nick has been made, and that is known as Argentina flag sign, which we have demonstrated in few other videos. Now the problem during phacoemulsification is that because the nucleus is not at all stable, so all the time nucleus is floating here and there, it's difficult to grip it. Here we can see that the nucleus simply rotates here and there. Instead of getting chopped, it dials. So there it's difficult to get a grip over the nucleus. More so, it's difficult to lacerate it using the horizontal chop method. And more so because there is hardly any epinucleus, so it becomes very tricky, because if one punctures or goes through and through the nucleus, which is again thin and atrophied, he will simply land up touching the posterior capsule, and that is going to be detrimental because these capsules are already very fragile, and if touched with a phaco probe with power or aspiration on, the capsule is going to rupture, and so there will be a PC tear, which will be an issue in management. Now presence of these floating particles or pieces of nucleus makes it a little challenging to catch hold of each of the nuclear fragment and emulsify them. So here we see how each fragment is caught hold of and emulsified at the pupillary level. One doesn't want to go very deep, and this is a continuous process, keeping in mind that you have to very judicially control your aspiration flow rate so that there is no collapse of the chamber or rising up of the posterior capsule because of a relative vacuum. Nucleus has been removed and we are now ready for implantation of intraocular lens. This is a hydrophilic monofocal intraocular lens. Incidentally, because the patient's keratometry was such that the steep axis was lying on my left hand side, so we have made a left hand incision, which is not my dominant hand, but still the surgery has been finished nicely. The IOL has been implanted, dialed into place. Because it was a steep cornea here in this meridian, so we are also making use of opposite clear corneal incision to compensate for the astigmatism, so that we have as little astigmatism as possible. Placing a clear corneal incision for controlling astigmatism is a good strategy because it doesn't involve any further expense for the patients. This is the first post-op day. There is some amount of IOP rise, but rest of it is fine. Thanks.